Before we get started, you have to understand which leads on the ECG correspond to which portion that's reading the heart. And what I mean by this is we group our leads into 4 different categories. So leads 2, 3 AVF, leads 1 AVL, V5, and V6, leads V1 and V2, and leads V3 and V4. These correspond, respectively, to inferior leads, lateral leads, anterior leads, and septal leads. Now, oftentimes, V1, V2, V3, and V4 are all grouped into one category of 4 leads, which we call anterior septal. And this is what that looks like. And the reason that this is important is because when you see different changes in these leads, you have to know which leads we're talking about. So if you see changes in 2, 3, or AVF, the pathology is inferiorly located. So those are the inferior leads shown here in green. Lateral is V5, V6, 1, and AVL shown in blue. V1 and V2 are anterior, V3 and V4 are septal, but they're oftentimes grouped into one big category where the 4 leads together are referred to as anterioseptal. So they just literally combine the words. So I want you to memorize that first. So pause the video and really get that down if you don't have it down already. But assuming that you do and you're comfortable with the way that these leads work, let's move on and talk about my mnemonic for remembering these leads. Because again, if you're not there yet, you have to have a way to memorize this because this is very important when you're taking your board exam. So I'm going to push that information to the left and draw my stick figure here. And when I was a medical student, it didn't really make a lot of sense to me that where the leads were in space corresponded to different parts of the heart. Now, if you're going to be a cardiologist, maybe you understand that geographic orientation, but I didn't go into cardiology. So I needed a different way to memorize this. So how I did this was with a few mnemonics. So the first one is 2 to 3 feet. And feet are the most inferior portion of the body, so 2 to 3 for leads 2 and lead 3. And feet for AVF, the F in feet for the F in AVF, and 2 to 3 feet are always at the inferior portion of the body, so I remember that 2 to 3 feet are inferior. I also remember that one hand with 5 to 6 fingers is lateral, so 1 for lead 1, hand with 5 to 6 fingers for V5 and V6, and then the hand is the lateral most part of the body, so that reminds me that these are lateral leads, and lateral for the L in AVL. You can use my mnemonics, you can do your fancy cardiology things that you try to do when you're a gunner and you impress people in medical school. But either way, as long as you know where the leads are, I'm fine with that. So this is a normal electrocardiogram, and I think it's really worthwhile to stare at some normal ECGs before we talk about the abnormal ECGs, because if you don't know what normal looks like, how the hell are you going to know what abnormal looks like? So really take this in. Some medical students really get scared when they see V1, V2, V3, and V4 because they see that the ST segment might be elevated, but I was lucky enough to do a rotation with a really, really great cardiologist when I was a medical student. And basically what he told me is that from V1 to V4, those ST segments are going to get a little bit bigger with each successive lead. So don't be scared. If it's rising proportionally, then it's normal. If they're super off the page, then obviously it's going to be abnormal. And we'll get into all that as we go today. But the reason that I bring that up is because a lot of medical students look at V1, V2, V3, V4, and they're like, wait, is this a STEMI? Is this an ST segment elevated myocardial infarction? But it should go up from V1 to V4. So this is normal. Stare at it, get comfy with it. You're going to look at the ECG. You're going to find if it's sinus or not, and you're going to find out if there's any other abnormal findings like ST segment elevation, ST segment depression, Q waves for different types of ischemia, etc. So I don't want you to come into this lecture being like, rate, rhythm, axis, don't do that. That's not going to help you on USMLE, and it's not going to help you on COMLEX. Here is where you look for P waves. Now, the best leads to find P waves, according to the cardiologist that I worked with, is lead 2 and lead V1. They're just the most evident in those leads. And I've drawn in here with black arrows some P waves in lead 2 and lead V1. And they're kind of subtle, but they're definitely there, right? You can clearly discern that there are P waves there. And where this gets tricky is medical students will look at an electrocardiogram and be like, oh, I don't know. Is that a P wave? Is it buried in the QRS? I don't know. Is that a P wave? Is that a little squiggly thing? Is that artifact? Everyone loves saying the word artifact. Is that artifact? No, it's a P wave. Look in lead 2 and lead V1 and find P waves. If you find P waves, it's a sinus rhythm. So here's our first one. The question is, what are we looking at? What kind of ECG is this? Okay, so pause the video if you want to think about it. But what you're seeing here is an ST segment elevated MI in the inferior leads. So what I'm showing you is the inferior leads, leads 2, 3, and AVF. See those red arrows? They are pointing to ST segment elevation. And the reason that I put the blue arrow in is to show you that comparatively, the ST segment of lead V3, which would be not in the inferior leads, is not elevated. So this is a STEMI localized to the inferior leads. Now, if you look at this ECG, I want you to theoretically ask yourself, what would have happened if you went through this with that dumb, methodical approach that they teach you in medical school? Well, rate, rhythm, what do I see? Axis, well, let's see, 1 is upright and AVF is upright, so the axis is normal. What does that get you? Where does that get you in this question? It gets you absolutely nowhere. Or you could just look at this and say, 2-3 AVF have ST segment elevation. Let me compare the ST segments to the other segments. Well, none of the other ones are elevated, so this is a STEMI. Is this sinus? Not that it really matters in this question, but we look at V1 and ICP waves. We look at 2 and ICP waves, so it's sinus. So it's a sinus rhythm, but there's an ST segment elevated MI. Done. Answer it, check the box, move on. That's what I'm saying here. Don't go through that methodical crap unless you're going into cardiology or you really want a mastery level understanding of ECGs. If you just want to dominate boards, do it this way. So this is a STEMI. What do we see here? Pause the video if you need more time, and in 3 seconds, I'm going to tell you. This is another STEMI, but this one is anterior septal, right? So look at the red arrows. Those are ST segment elevations that corresponds to V2, V3, V4, V5, and V6. So V5 and V6 are lateral, and V2, V3, and V4 are anteroseptal. So we combine them, and we say this is an anteroseptal lateral STEMI. And then look at the blue arrow, right? Look at AVL. Not really elevated. So we can localize this mostly to V2 through V6, which would be anteroseptal lateral or anterolateral. Now, on a test, they could simply ask you what type of STEMI is this, and you would pick the answer that says anterolateral or anteroseptal lateral. Or they could flip it on you and in the vignette describe the leads with the ST segment elevation, or describe even the name. They could say something like anteroseptal lateral and then ask you which leads you would expect to find the ST segment elevation. And that goes back to my point. It's very important to be able to correlate leads to location. So those are STEMIs, and STEMIs are the highest yield ECGs that you could probably see on USMLE and COMLEX because they're pretty easy to get. And to be fair, guys, on USMLE and COMLEX, they have to give you very straightforward ECGs. They can't make it too challenging. If they did, it would be way beyond your level as a medical student, and everybody would get the question wrong. And one of the themes of USMLE and COMLEX is that the questions really can't be controversial. So that is an anteroseptal lateral STEMI. Let's move on to the next example. What are you seeing here? Now, this one's a little trickier. It's a little more subtle, but as soon as I point out the answer to you, I don't think you'll ever get this wrong again. So pause the video if you really want to look and dissect this ECG, but in 3 seconds, I'm going to give you the answer. This is Wolff-Parkinson-White Syndrome, and what I've highlighted here with the red arrows is what's called a delta wave. Now, a delta wave is a slight upslanting of the beginning of the QRS complex. And this is classic of Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome has these delta waves, these slight upslanting of the QRS. And if you really put on your bifocals and zoom in here, you can see that upslanting portion of the QRS. Now, in real life, this is a pretty rare disease. But on USMLE and COMLEX, it's pretty high yield because that subtle finding, that upslanting of the QRS, should tip you off that this is WPW syndrome. And then from there, they can go in a whole bunch of different directions by asking you things about pathophysiology, about the treatment for Wolff-Parkinson-White syndrome. If you see the answer procainamide, that's the answer. But Wolff-Parkinson-White syndrome, very, very high yield. Be able to recognize this upslanting. And again, I'm just really going to hone in on this. You don't have to dissect this ECG and go, rate, what's the rate? Rhythm, what's the rhythm? Axis, what's the axis? You see the delta wave, the answer is WPW. So what the hell is the point of doing the methodical, dumb, unnecessary waste of time method that you're seeing in all these other YouTube videos, okay, guys? Look for the pathological findings and answer the damn question. It's that simple. WPW has the delta wave that upslants. Done, moving on. What do you see here? This is a very, very high yield ECG, and it may not be obvious at first, but I want you to pause the video and look around and see if you can tell me what we are looking at on this ECG. This is atrial fibrillation, and almost equally as high yield as STEMI, if not more. So AFib is very, very high yield because it's so easy to recognize. You don't see P waves, and it's irregularly irregular, right? So in irregular intervals, it's irregular. So that's what irregularly irregular means. And what you see there with the blue arrows is that the width between the QRS complexes is irregularly irregular, right? They're skipping different widths. That is classic of AFib. And if you look up at the other leads, you will not see discernible P waves. You see a lot of squiggly crap, but there's definitely no discernible P wave in lead 2 or lead V1. Okay, so this is AFib, very, very high yield because they can get into pharmacology, they can talk about rate control, they can talk about rhythm control, they can talk about hemodynamic changes and pathophysiology, but you have to be able to recognize an irregularly irregular ECG with no P waves. So again, rate, rhythm, axis, that doesn't get you anywhere. The question is, are there P waves and is this sinus? In this case, the answer is no. And then you would look at this ECG after seeing that it's not sinus, which eliminates a million things that it could possibly be, and you'd see that irregularly irregular QRS interval, and you'd say, it's AFib, I'm done, I got the point, and I'm moving on. That is atrial fibrillation. This is our next example. What is this? Pause the video if you need more time, but I'm going to give you the answer. This is atrial flutter, and atrial flutter also has no P waves, just like AFib, but the big difference between atrial flutter and atrial fibrillation is what's classically referred to as the Sawtooth Pattern, and I've superimposed it on the slide for you to really be dramatic about what it looks like. But on USMLE or COMLEX, they have to give this to you. They can't give you an A-flutter question without the sawtooth appearance because you just frankly won't be able to answer the question. So if you see that really choppy sawtooth pattern, it's A-flutter, stop what you're doing, pick it, and move on. So A-flutter has no P waves and it's got the sawtooth pattern, sort of like AFib in that the rate is similar and maybe the appearance is similar in terms of no P waves, so it's not sinus, but look for the sawtooth appearance. So that is atrial flutter. So guys, I want to pause for a second and highlight something here. We are flying through this lecture, but what I'm showing you is that you don't need to dissect ECGs like a cardiologist. Instead, you should be dissecting ECGs like a medical student because, hey, after all, you are one. So look for P waves, and after that, just look at the ECG and get the pathologic finding because it's going to be obvious. So we've done AFib, we've done A-flutter, we've done STEMIs, and we've done Wolff-Parkinson-White Syndrome with the upslanting delta wave. Let's move on and talk about some other really, really high-yield ECGs that don't get a lot of love in other review sources, but I think you should know because if you could pick them out and correlate them to something in the vignette, you're giving yourself free points. So this one's really tricky, and to be honest, I don't expect you to get this until I teach you what it is, and then from that point onward, hopefully you'll never miss it again. But pause the video if you want to look around on this ECG. I'm going to give you the answer in 3 seconds. So this is actually a pulmonary embolism, and what this is called S1Q3T3. Now this is tricky, and it's honestly beyond the level of a medical student, but it still shows up on USMLE and COMLEX because of how high yield it is in terms of being able to correlate this with a pulmonary embolism. So for whatever reason, when somebody has a very large PE, and this is more likely in something huge like a saddle embolus, they get classic findings on the ECG. And what those are shown here on this slide. So the S1Q3T3 refers to a deep S wave in lead 1. So the S wave, when it comes down, will go deeper than it normally should. So S1, S wave that goes very deep in lead 1. Q3 means a deep Q wave in lead 3. So normally the Q wave kind of drops down a little bit, but if it really goes deep, that's Q3. And then T3 stands for inverted T waves in lead 3. So a pulmonary embolism, you really need to just look at leads 1 and lead 3. And if you see the deep S, deep Q, and inverted T, you should think pulmonary embolism. Now, I want to be honest. If you're on your exam, this is probably going to be a choice of elimination. And I remember when I was taking my exams, if I had S1Q3T3, but I couldn't recognize it by reading the electrocardiogram, I would eliminate all of the other answers first. And if I saw pulmonary embolism as a possible answer choice, then that would cue my brain to look back at the ECG and be like, oh, maybe there's an S1Q3T3. Let me take a look. And so you want to use the answers that they're giving you to look for the associated features. So for example, if you have A, B, C, D, and E as your possible answer choices, and it's like AFib, A-flutter, Wolff-Parkinson-White, inferior STEMI, and pulmonary embolism, what should you look for? So if the answer is A-flutter, look and see if there's a sawtooth pattern. If the answer is A-fib, look and see if it's irregularly irregular with no P waves. If the answer is inferior STEMI, look for ST segment elevation in leads 2, 3, and AVF. If the answer is Wolff-Parkinson-White syndrome, look at the QRS complexes and see Is there an upslanting delta wave? And if it's a pulmonary embolism, look to see if there's S1, Q3, T3. So that's the way that you should approach these. You should look for the pathognomonic finding associated as a buzzword with your answer. So that is a pulmonary embolism, S1, Q3, T3. Let's move on to our next example. What do you see here? Now, I'll give you a little hint. I'm not looking for an answer to like a disease here. I'm looking for sort of a symptom. Pause the video if you need more time, but in a few seconds, I'm going to give you the answer. So this is actually showing hypokalemia or low potassium. And what you're seeing here is what's called a U wave. Now, I put something on top of the slide here to show you the difference between the ECG when it's normokalemia, which means your potassium is normal, and the ECG when you have hypokalemia. So now normally the T wave comes up and it's normal in size, and then after it you see a small little bump, which is a very, very shallow U wave, if at all. Now sometimes that U wave won't even be there, but if it's there and it's normal, it's going to be an ever slight little bump that's significantly smaller than the T wave. But in hypokalemia, you get prominent U waves. So instead of the U wave being very, very small compared to the T wave or even absent, it's much, much larger than the T wave. So what you see on the ECG that I've shown with the blue arrows is a prominent U wave that's come up and is bigger than the T wave. And if you see that, you should think of hypokalemia. Now, the reason that this is high yield on USMLE and COMLEX is because if they're going to show you an ECG with hypokalemia, they're probably going to have you tie it in some way into a pathophysiology question or a pharmacology question asking you about hypokalemia. So if you see this, they're going to ask you an associated question, which probably has to do with the cause of somebody having a low potassium. So this ECG is often used to tie in high yield associations, which is why I've included it in this lecture. It's extremely high yield. So you see those U waves, it's hypokalemia. Start to have your brain think of causes of hypokalemia because that's probably where the question is going. Here's our next example, and obviously we just did hypokalemia, so you can probably take a guess that this ECG is going to be something similar. This is hyperkalemia. So hyperkalemia shows what's called peaked T waves. So the T waves kind of get really sharp and spiky, and they come way up off the paper. Now, I've superimposed something on this slide which shows you how the peak T waves appear in the different leads from V1 to V6. And the reason that this is important is because some medical students get mixed up between a peaked T wave and ST segment elevation because they're seeing the T wave come up and they're not sure if that's ST segment or if that's just an isolated T wave that's peaked because of hyperkalemia. So what I want to show you is that in these different leads, if it's a peaked T wave, it's kind of like somebody grabs the tip of the T wave and pulls it straight up. But if it's an ST segment elevation, they have to grab the whole segment, right? From the S to the T. So instead of it being a really spiky thing that you could like cut your finger on if you touch the tip of it, that's what a peak T wave is. ST segment is more blunted, right? It's more rounded at the top because it's the whole entire segment. And I really want to hone in on that because people will think that this is a STEMI from leads, say V2 to V4, but this is really just a peaked T wave. Now, hyperkalemia can lead to a STEMI, but you have to be able to differentiate those two. So in summary, a peak T wave is very sharp at the top, but ST segment elevation is more blunted at the top, more rounded at the top. So be able to keep that straight in your head. And just like hypokalemia, hyperkalemia is going to be about some type of association, and the question will no doubt ask you about pathophys or pharmacology leading to elevated potassium. This is our next example. This one, a little tricky at first, but hopefully after I point this out to you, you'll never get this question wrong because this is very high yield. What do you see on this ECG? Pause the video if you need more time, and in 3 seconds, I'll give you the answer. What you're seeing here is actually a prolonged QRS segment. And what you'll see causing this is tricyclic antidepressant toxicity. So if someone overdoses on any one of the TCAs, it prolongs their QRS. And that can be really dangerous. It's not something that you want to mess around with. And if you've memorized your pharmacology already, you know that TCA toxicity leads to cardiotoxicity. And this is how. The prolonged QRS segment can lead you into dysrhythmia and cause death. So you need to treat it very, very fast, and the treatment for TCA toxicity is bicarb. So bicarbonate will reverse the prolonged QRS. But look at the blue arrows. Look at how long those QRS segments are actually lasting. Even if you know nothing about ECGs, but you've just been staring at normal ones, you should be able to appreciate how long these QRS segments are. So if you see a prolonged QRS on USMLE or COMLEX, they're telling you that someone overdosed or inadvertently took too many TCAs, you pick bicarb as the treatment, prolonged QRS is the ECG answer, be able to correlate all of that stuff because it's incredibly high yield. Here's our next example. What do you see on this slide? Pause the video if you need more time, and in a few seconds, I'll give you the answer. What you see here is pericarditis, okay? Pericarditis classically causes diffuse ST segment elevation in most leads and diffuse PR segment depression, especially prominent in lead 2. So what I've shown you here is the blue arrows and the red arrows. And what the blue arrows are showing you are PR segment depression. So normally the PR segment should not be depressed under the line. It should not go in the negative direction. But look at the blue arrows. The PR segment's moving downward. So that is PR segment depression. The red arrows are showing you diffuse ST segment elevation. Now you might look at this at first and be like, oh, is this a STEMI? I see ST segment elevation. And that could be possible, but what you need to appreciate is that the ST segment is diffusely elevated in all of the leads. And of course, it'd be very rare to have a STEMI in every single lead at once. You wouldn't be infarcting all of the vessels at your heart at once. So this is probably pericarditis. What will seal the deal for this question is the clinical vignette. They will give you something extremely suggestive of pericarditis. So they'll give you all of the other symptoms of pericarditis and then show you this ECG or vice versa and want you to tie these symptoms together. So be aware that for pericarditis, you will see ST segment elevation, but you'll see it in all leads. You'll see PR segment depression, and if you see that on USMLE or COMLEX, your brain should instantly think about pericarditis. Here's our next example. What do you see on this slide? Now this one I will tell you is probably the trickiest of any of the ECGs that I've included in this video today, but this one is really important to understand, and we're going to spend a little bit of time on this because I think that understanding this is very, very high yield. Pause the video if you need a few seconds, but I'll give you the answer. What you're seeing here is multifocal atrial tachycardia. Now, I'm going to be honest. When I was a medical student, this was one of the ECGs that I got really nervous about because I didn't really understand what the word meant. Multifocal, coming from different areas. Atrial means atrium, right? The atrium of the heart. Tachycardia means fast heart rate. So this is a fast heart rate that is due to the atrium originating from multiple areas. That is literally what multifocal atrial tachycardia means. And what you see here is that there are 3 or more different P wave morphologies, which all that means is that there are P waves and at least 3 of them look differently. So let me explain this. And I've superimposed a really clear-cut example where the black arrow showing you 3 different appearing P waves. In lung disease, now this is classically associated with lung disease, so something like COPD, you have elevated pulmonary pressures which cause the atria of the heart to contract irregularly. And all the atria technically have foci that can generate electricity and cause impulses through the heart. Now, normally the sinoatrial node handles this, but in lung disease, there are different areas of electric activity that are incorrectly generating electrical impulses. So you see different P waves because there's the sinoatrial P wave, but there's also the irregular P wave or the abnormal P wave, if you will, that's generating impulses due to lung disease causing pulmonary backup into the heart. And when you see that on the ECG, you'll see different looking P waves. One is sinoatrial, one's coming from the atrium closest to the pulmonary system, and you have all of this mismatch in electrical activity, which causes you to see different P waves on the electrocardiogram. So if you see 3 or more different P waves, it's multifocal atrial tachycardia. And the reason that it's so high yield is A, because the P waves will look different, and it's a very subtle finding that they want you to be able to notice on an electrocardiogram, but also because it's classically associated with lung disease. So look in the vignette. If they're giving you somebody who has COPD or asthma or pulmonary hypertension or sarcoidosis or whatever it is, it's probably going to be multifocal atrial tachycardia. So remember, MAT is associated with PFTs. That was my mnemonic. MAT for multifocal atrial tachycardia is associated with PFTs or pulmonary function testing. Somebody with abnormal PFTs will have abnormal MATs. 3 or more different P waves because the heart is sending impulses from different areas because the lung disease is causing aberrant electrical activity of the atria.